On-the-scene video coverage of ESC 2012 is supported by Pradaxa.
Welcome to On the Scene Video ESC Highlights Final Edition. 4 trials reported as hotlines here delivered take-home messages that may influence clinical practice. Trilogy ACS, Shock IABP, FAME2, and WOEST. FAME2.
So this was a study of several hundred patients looking at a strategy of FFR-guided PCI with optimal medical therapy versus optimal medical therapy alone, and found a benefit of the FFR-guided PCI strategy. Now, this seems to go a little against what we think of in COURAGE of optimal medical therapy alone, was consistent with equal numbers for death or MI, but I think an intriguing strategy that could help guide PCI. Fred, what do you think of this study?
Well, I think it does help us in patient management. You know, when we see an intermediate lesion on the angiogram, we're never quite sure what's going to happen to that patient, and FFR tells us whether it's significant or not. The data from FAME2 is suggesting that we can predict that about 1 in 5 of those people with a positive FFR is going to get in trouble within a year. In COURAGE, I think the message we got was most of these patients are stable, and if they destabilize, we're going to go back and intervene. Here, we can at least get some idea to predict who's going to do it, but again, it's going to be 1 in 5 of the people with a positive FFR.
This has a chance to be the most discussed trial in this whole meeting. It's going to be the hottest thing since COURAGE trial because everybody is focused on what to do with stable ischemic heart disease. Should you stent them or should you treat them medically? This trial is going to be highly controversial, I predict, because of the early stopping, but also because this trial is positive in its primary endpoint. There's going to be a lot of excitement from the interventional community. Okay, now stenting has been resurrected in stable ischemic heart disease. On the other hand, there'll be criticism that it's readmission for admittedly unstable conditions, but there'll be the criticism that that's somehow confounded, and unless we see a mortality difference, people will criticize the result.
And finally, WOEST.
We had a terrific presentation of an investigator-initiated study that looked at the most vexing group of patients we deal with, patients who require anticoagulation for either AFib or a mechanical valve who then need a stent. This is a problem that the investigators looked at dropping aspirin as a strategy. So they compared the triple antithrombotic therapy with warfarin, aspirin, and clopidogrel to a strategy of warfarin and clopidogrel alone. And they found very interesting results. Not surprising, there was less bleeding when dropping the aspirin, but also trends toward fewer MIs and a significantly lower mortality. This was a moderate-sized study, about 600 patients, but really terrific results, I think.
This is a big problem we run into. We have a patient in AFib, and some event occurs. All of a sudden, they need aspirin, they need clopidogrel, and now we're increasing the bleeding. This is particularly a problem in the elderly patient. You know they're going to bleed like this. I think this is very useful information. It says if we want to preserve the value of the anticoagulation and the value of the antiplatelet therapy, we can do it without the aspirin and reduce the risk of bleeding. I think it's a big help in managing these patients.
That wraps up On the Scene Video from the ESC. Join us in Miami Beach in October for On the Scene Video from the TCT.